Okay, I think we're gonna get started. So good afternoon, everyone, and good evening for our European colleagues. So welcome to today's Neonatal Hemodynamic Research Center site presentation. Today the topic will be weaning from ECMO and how to determine cardiopulmonary readiness to uncouple from the cannula. I am Maky Fraga, I'm one of the neonatologists at the Children's Hospital of Philadelphia, and I'll be your moderator today with Dr. Florian Kipfmueller. He is the Division Chief of Neonatology and Pediatric Critical Care at the University Hospital of Mannheim in Germany. So welcome, everyone. Before we start, I would like to just say some general housekeeping items to make note of. Please make or use the Q&A feature to post all your questions. And actually, we will be answering those during the Q&A session at the end of Dr. Gowda's presentation. Also, this webinar is being recorded as well. So now to our main talk. Our guest speaker today is Dr. Sharada Gowda. She's a board-certified neonatologist with cardiac critical care training. She works at Texas Children's Hospital, and she's also an assistant professor of pediatrics in the Division of Neonatology at Baylor College of Medicine. So her research interests include management of congenital heart disease, ventricular dysfunction in congenital diaphragmatic hernia, and extracorporeal life support as well. She's also a good colleague of mine, and she has put a lot of efforts in helping developing our national neonatal point of care ultrasound collaborative. So joining Dr. Gowda, today we will have Dr. Rachael Hyland, Dr. Diana Vargas, and Dr. Anne-Marie Guerguerian, who will be participating after her talk in our panel discussion. So Dr. Rachael Hyland is a neonatologist and a clinical assistant professor of pediatrics at the University of Iowa. She completed her fellowship and also advanced ECMO training at Washington University in St. Louis. And then she moved to Iowa to complete the neonatal hemodynamic fellowship. And then she stayed there as an attending. Dr. Diana Vargas, she's not on yet, but she will be joining soon. Diana is the medical director of the neonatal ECMO program at New York Presbyterian Hospital, and she's an assistant professor of pediatrics at Columbia University. Diana has dual training. She's done neonatology and pediatric cardiac intensive care, where she did this at Pittsburgh. And she specializes in caring for infants with congenital heart disease and CDH as well, pulmonary hypertension. And also Diana is actively engaged in national efforts to standardize the use of point-of-care ultrasound in the NICU through the National Collaborative. Lastly, Dr. Anne-Marie Guerguerian. She's a colleague from the PICU, critical care, staff physician in the Department of Critical Care Medicine, and she's also the medical director of the extracorporeal life support program at the Hospital for Sick Children in Canada. So her research program is focused on neurologic injury, and she aims to develop methods to quantify brain injury during acute critical illness. So I'm going to stop here. So now, Dr. Gowda, please take it away. I'm going to ask everyone to turn off the camera and the microphone. Thank you.
Thank you, Dr. Fraga, for that wonderful introduction. I am going to start sharing screen right now. Please let me know if you're able to see the slides.
Yeah, not yet. It's a blue screen.
Okay.
Yes.
Hopefully this is happening right now. Okay, wonderful. Welcome, everyone, and thank you to the Neonatal Hemodynamics Research Consortium for giving me this opportunity to talk about something that is very near and dear to my heart. It's cardiopulmonary interactions in ECMO and readiness to uncouple from the cannula. What are some of the factors that determine and how do we approach that? I do not have any financial disclosures. If I can minimize the screen, that would help me a little bit. Today I'll be talking about brief discussion and description of physiology of ECMO, because without that, we cannot really uncouple or decannulate. Brief discussion of the myocardial energetics on ECMO, on assessing readiness from heart and lung interaction perspective, and share some protocols from literature so that maybe if you don't have that at your institution, you can take away this today. So there are specific criteria for initiating ECLS. ELSO has done a fabulous job of protocolizing and helping every institution come up with when to actually start a patient on ECMO. It is a bridge to recovery. It is a bridge to transplant. It can be a bridge to final diagnosis and decision or goals of care. For an intervention that utilizes such significant resources, evidence to initiate is very well studied. However, weaning from ECLS is not as robustly studied. So we really need to come up with our own guidelines and try to spread the wealth of knowledge. So basics of ECMO, and especially the oxygenation gas exchange part of it and QPQS quotient is an important physiological basis to determine first. In VA ECMO, we know arterial ECMO, we measure the adequacy of gas exchange and end organ perfusion by measuring systemic venous oxygen. It is mixed venous saturation of about 65 to 80%. PaO2s range between 60 to 80 millimeters of mercury, but saturation goes greater than 90%. In this mode of ECLS, there is minimal participation by native ventricle and diminished pulsatility because we have all the deoxygenated blood, as I will tell you in the next slide, that's going to be drained from the right atrium and then returned to the carotid artery, and thus bypassing both the pulmonary and systemic circulation to some extent. And there is decreased pulmonary blood flow as a result, and oxygenated blood completely bypasses the QP. In VV ECMO, we have ranges of PaO2 between 40 to 60 millimeters of mercury, saturation is mid-80s, native cardiac function and pulsatility is generally preserved, and oxygenated blood goes to QP because it is returned to the right atrium and across the tricuspid valve, and then it reaches the pulmonary circulation. That's also encouraging some pulmonary vasodilation and coronary perfusion with better CaO2 that I'll talk to you in just a second. As you can see here, you see the coronary perfusion in the VA ECMO is going to be a little bit less oxygenated because you have the deoxygenated blood that is drained from the IJV from the right atrium, and what is returned, the oxygenated blood returned to the carotid artery. So like whatever blood is left in the left ventricle is really not that very well oxygenated because, as I mentioned before, you don't have the QP that's participating in gas exchange. Additionally, LV afterload is increased. You have a big old cannula that is stuck in this, the first branch of the aorta, and so the LV has to pump against much more resistance with less preload and with less CO2 to the coronaries. And all these are going to strain the LV myocardium quite a bit. And mostly these babies might also have pulmonary hypertension, and that can be another added burden as well. In VV ECMO, we have the obviously, as you can see here, it is a dual lumen cannula. You have the venous component, the arm of it, that is going to be draining blood. And then this is your oxygenated blood part of it that is preferentially streamed against the tricuspid valve, which then goes to the pulmonary circulation. So here you have better CaO2 in the pulmonary artery and vasodilation. You have better afterload myocardial energetics because you don't have a whole lot of the cannula in the carotid artery. LV preload is preserved, and so is your coronary arterial CaO2 as well. So arterial oxygen content is actually much better. And RV preload is preserved because you have this blood that is returning to the across the tricuspid valve into the right ventricle. So just to expand a little bit more, and I promise I'll shift after this, with prolonged afterload increase on an already struggling myocardium, left ventricular end diastolic pressure and left ventricular end diastolic volume alters the loading conditions. It may increase pulmonary edema, it may worsen the oxygenation, and it can also diminish the coronary perfusion, thus leading to myocardial ischemia. And longer you continue to subject the myocardium to this afterload, there is decreased myocardial recovery. And when you have such poor functioning left ventricle, you have decreased aortic valve opening, leading to LV stasis and thrombosis. So really, it is very important for us to start thinking in terms of let us decannulate from the day you actually put the patient on pump. In the purest sense, weaning from ECLS really is is defined as decannulation and no further requirement for mechanical circulatory support for 30 days. That means like no Berlins, no LVADs, nothing, no mechanical circulatory support at all. While difficult to prove in neonates, we do know that ECMO alters systemic neurohormonal milieu to quite an extent, and it reduces the atrial natriuretic peptide production, and because you have decreased myocardial stretch. So both this decreased myocardial stretch and also the neurohormonal imbalance can actually continue to be a vicious cycle. So we really need to focus on as soon as possible, early evaluation to decannulate minimizes ECMO complications. So what is the utility of weaning trial, you ask? VA ECMO flow increases afterload, decreases preload, intrinsic LV function is masked. So with all these things, we need to see if the left ventricle, when the shifting, the loading is changed, if you give additional volume, can the left ventricle tolerate it and be able to function? Is its recovery occurring at the time and in a timely manner so that you're not setting up for failure? So that really is what this trial tells us. If you can continue to monitor the function in real time very closely to the adaptation and looking at the quality and quantitative functional assessment, that tells you a lot of a story about, okay, now do you need to give a little bit of volume? Should we think in terms of inotropy? Should we think in terms of SVR reduction? Should we think SVR augmentation? What is it that we want? All these things actually help us uncouple from the ACLS. When should we consider really? Ideally, the team should really discuss decannulation readiness every single day after ECMO cannulation during rounds. Clues to myocardial recovery include assessing the heart rate, the pulse pressure on the monitor, pulsatility on the arterial waveform, and when possible, obtaining an echo to assess ventricular function and noting whether it's returning to baseline or if the vasoactive infusion needs are decreasing. So noting objective data that suggest pulmonary function improvement are some of the sweep flow, like you can, the sweep flow requirement is gradually decreasing, your CO2 is going down more than you anticipate with just pump alone. So that kind of tells you, okay, maybe it is time for us to start recruiting the lungs. Even before you actively recruits the lungs, you might notice on the mechanical ventilation, even at rest settings, if you do the rest setting on patients who are on ECMO, you can see the tidal volume shifts a little bit once the function is recovering, and also the lungs are able to participate in gas exchange. So that is something that we can also look in terms of, and of course, the last thing that I really want to emphasize on is the compliance of chest wall. What is your fluid status? What is your intake and output? Are you able to maintain adequate urine output or maybe renal replacement therapy so that you reach euvolemia and minimize any third spacing or capillary leak syndrome? And so those are the things you have to pay specific attention to. So it goes without saying that most critical factor to consider is a reversal or improvement in etiology for initiating ECMO. So that goes without saying. The successful removal rate, defined as percentage of patients surviving to decannulation, has been proposed as a useful construct in evaluating liberation protocols. However, this binary outcome, while it is, clinically important, we have some of the strongest determinants of successful removal rate may be unmodifiable, like maybe a congenital diaphragmatic hernia with significant pulmonary hypoplasia, or you have a sepsis, unrelenting sepsis, or fungemia, bacteremia, or pulmonary hypoplasia that can really not be reversible just because now it's the patient who's been has Potter sequence and things like that. So really, the underlying etiology does play a significant role as well. On the flip side, if we continue to deliberate and delay in deliberation, may lead to higher complication rate, like I mentioned before about the neurohormonal imbalance, and also like the prolonged hypoxia to the myocardium, because now the coronaries are supplying deoxygenated blood to the myocardium and there's ischemia, then that can also further contribute to delay in decision to liberate. So it's like a vicious cycle, like you're waiting, but then it's really not helping, but hurting on that side. Now, there's a few important considerations to ensure timing of all interventions, such as how can we determine what is the right time to start lung recruitment? What are the pressures on the mechanical ventilator that you can safely say, okay, I'm comfortable with this, and therefore I'm going to start volume guarantee at X, Y, and Z number, and then my Pmax is going to be such and such. Every institution has a threshold. Some are more, I guess, heroic than the others, and I've seen that practiced in a wide variety of ways. Needless to say, no matter what your institutional practice or criteria is, ensuring chest wall compliance is adequate by optimizing fluid balance, establishing FRC by optimal lung recruitment are really important. And it also goes without saying that preparing the right ventricle is another important aspect as well. Whether you need to give inhaled or systemic pulmonary vasodilators, or trying to also make sure if there is any strain pattern on the right ventricle, do we need to now use prostaglandin to act as a pop-off valve? That's another important aspect as well. And determining cardiac readiness, like I mentioned before, reviewing prior echocardiograms and looking at the qualitative and quantitative function is important. Pulsatility of the waveform, NIRS, if that's something that you routinely measure, and parameters of right and left ventricular function, both qualitative and quantitative, as well as if you're thinking of RV pressures and TR jet, your TAPSE, looking at those parameters and improvement to via serial echocardiograms certainly help make these decisions quite easily. Well, I don't know if it is easy, but definitely more, it gives us more objective information, and we're not just flying in the blind. One other component is the septum. The septal disposition is an important, and as Dr. Kipfmueller and Dr. Patel have extensively published, septum and the left ventricle are very important components of overall myocardial contractility, and the disposition does play an important role in liberation. So if we need to decrease the PVR or SVR augmentation or inotropy, we have to pay close attention to the septum and titrate the vasoactive infusions. So even though this is, just go back. So if you see in this pictogram, you can see the pulsatility, kind of like, the narrow pulse pressure, and then you can see as the myocardium is recovering, you can start seeing better pulse pressure variability, and also the pulsatility kind of changes. And obviously this is condensed over a few days, and then you can see the preductal and the postductal changes as well. That kind of tells me if I have a major pre-postductal gradient, tells me, okay, maybe there is RV pressures that are elevated, there is right to left shunting, and then therefore now I may need to think more in terms of pulmonary vasodilator, and then optimizing my right ventricle and the septal position. So here, sorry, so far I have had no echocardiograms, but I promise they are coming soon. Which ventricle here would be ready to participate in liberation? If you look very closely, I'll start with number C here. The picture C here. If you can see, the patient's coronaries are being perfused by the ECMO oxygenated blood. So you know by this picture, the LV function is really not great. And this is definitely not a ventricle that is ready for prime time or to participate in any liberation. However, if you look at, and the asterisk is where the mixing is happening between the flow from the native cardiac chamber and from the oxygenated blood that's returning to the carotid artery. So if you can see here, it's really not a whole lot of contractility. Maybe this ventricle needs a little bit more time, or maybe not. Here, there is better recovery, and therefore this baby probably can, with help of better LV loading conditions and some volume resuscitation and some inotropy, might be able to partake the load and participate in ECMO liberation. And the same thing here as well. This vertical is certainly ready. And this one maybe give some more, a few more days, or just test it a little bit and see if that helps. And another important aspect of liberation is truly the organizational and human factor considerations. There is interdisciplinary composition. ECMO is a team sport. It is not, I'm doing this all by myself and therefore what I say goes. It's never like that. We have multidisciplinary, interdisciplinary, and interprofessional team members, and all have unique responsibilities. So making sure all these folks are part of the decision making and they're available when we are trying to say, for example, when you're trying to recruit the lungs, the respiratory therapists are there at the bedside and they're giving you real-time data saying, hey, you know, when I went up on the PIP, this happened, or when I went up on the tidal volume, this happened. So, and they're there to run the gases back and forth. So things like that. So that's important. And determine what works best for institution to do the optimal time for trialing. Is it morning? What if everybody is busy in rounds and such? Maybe early to midday after rounds. Maybe that works best for some folks and maybe not for the others. So like you determine what really works for you. And what are the other resources that need to be notified in advance, such as cardiologist or hemodynamics consultant to do real-time echocardiography, and of course the OR or the anesthesia team. So you have seen pulsatile flow on the arterial waveform. You've already recruited the lungs and there is recovery. Not a whole lot of vasoactive support required for this patient. Now, I think the baby is ready to decannulate. How do we go about it? The Weaning trial is done. I looked at quite a few studies, and then most of them, unfortunately, are adult literature. However, we can take away a whole lot of information from that and then adapt to us with the understanding neonates are not little kids or little people. And our myocardial energetics, especially with the contractile tissue being as low as it is, we have to think differently about the myocardial energetics. And our inotropy and that we use is tailored to our physiology. There are multiple iterations of standardized weaning protocol, and thoracic echocardiogram is what obviously we do in neonates. And this specifically talks about baseline at 80% flow, and then they go down to 50% and then to 33%, and then they do an inotropic challenge. And there's another a few studies that talk about multiple studies of echoes at different loading conditions and such. All I'm trying to say is at this point, we need to assess the functional component of the biventricular phase and also assess the hemodynamic stability with gradual decrease in the flows. So that is the most important thing. And then you have to assess the criteria to attempt ECMO weaning. Because if you don't have preset criteria, people are going to be doing it at different times, some really soon, some really late. So really having a protocolarized approach is a recipe for success. And therefore, I'm going to present to you the Texas Children's Way. So this is an example of a note template. At Texas Children's, liberation is really viewed as a process of discovery almost, because we want to, if you're curious, can this baby really tolerate the flow reduction of the circuit and then increase in the native circulation? So after morning ECMO round, this is our note template. So the decision was made to attempt a trial off of ECMO, and then this is our current ventilator setting, and then the ECMO flow. This is when we do the baseline echo. This is the first echo time. And then we also document what vasoactive medications we are on and what sedation infusions are going on and what's our current anticoagulation management. Because remember, at the end of the trial off period, you also clamp the circuit for a little bit, and it is a tiny baby with circuit that's clamped. That is the recipe for prothrombic phenomenon. So, and then a baseline ABG with lactate prior to trial off. So that would be the first ABG in the table that I'm going to be showing you in just a second. This is how the flow sheet goes. This is when it first started, and it is our baseline flow is 80 mLs per kilo per minute. Obviously, if the patient needs 120 per kilo, that's what we start. 150 per kilo, that's what we start. But then we gradually decrease to 80 per kilo, and then get our baseline echocardiogram, and this is what it says. There's a small PDA or a normal function. And then we go down to 70% and then start to see here, you start noticing a little bit of TR jet and the septal flattening, but the function is still intact. So, okay, like this is good, this is good. And then we go down further to 60 mLs per kilo per minute. And then you look at the need for any further sedation or anything like that. And here, if you notice, from the blood flow, at 80 mLs per kilo down to 60, you can see the blood pressure changed a little bit and your heart rate changed a little bit as well. So, close attention to this and also monitoring the NIRS at the same time kind of helps us titrate the sedation, titrate your vasoactive medication, and if need be, once you get the gas, you also get your vent changes as well. And then down to 40, and then you can see that gas actually is pretty good. Like, see how on 80 per kilo, the PCO2 is 42, and now we're able to bring that down, and there is no lactic acidosis. And we continue to look at our parameters on the echo. And then at about after 40, we go ahead and clamp and then do an echocardiogram again. Usually we do about 10 to 15 minutes, and then we do flash of heparin or bivalve in between, and then go from there. So once you notice that, if you can see here, 5 minutes after the clamp, the LV was mildly depressed in function. So you start to titrate your vasoactive medication and then get another echo looking for functional improvement. So this is what we actually wrote our experience. And I really do think this real-time echocardiogram kind of helped us to streamline our process of decannulation to a large extent. These are our medications that we routinely used. And if you see here, pretty much everybody has pulmonary hypertension. Therefore, all of them required INO and sildenafil and after lung recruitment. So that's something that, and then in 7 out of 12 patients, we had epi infusing prior, but then we titrated, obviously, to effect. So this is our flow at 70%, and then you can see that we are doing the functional assessment here. Again, this is baseline echo, where parasternal long axis, this is your right ventricle, this is your left ventricle cycle, and I thought I had the colored ones. I apologize for that, but so the PFO was bidirectional at this point, and so we ended up having to titrate the vasoactives again. And this is after the clamp of 7 minutes, and you can see with epi titration, the patient tolerated the clamping trial pretty beautifully. So that kind of tells us that real-time data to interpret changes in cardiac loading conditions, echo serves as a great tool. And it also tells us the dynamic changes with flow, afterload, and preload alterations. And this RT weaning model provides such unique opportunity to interpret and teach where, say, for example, not all ECMO members could be there, or for fellows to learn, you can go back and show them, hey, see, this is why we had to titrate the vasoactive medication. This is why we had to halt our progress to clamp off trial. And it helps us guide interventions with tailored vasoactive medications and timely decannulation, thus minimizing any complications. So I spoke a lot about weaning from VA ECMO, but as you might know, no surprise here, not much was in the literature for true trial off from VV ECMO in neonates. However, I really liked this one in, again, an adult study, but I like the way they talk about here. Treat the underlying pathology, optimize hemodynamic support, and await resolution of underlying pathology and improving lung compliance and hemodynamic stability. This goes without saying, right? Because here the ventricle has always been participating. So you really are not going to decrease the flow or anything. You're just going to shut off the sweep gas. And then recruit the lungs, choose your target ventilator settings, and then you can go ahead and see if the patient is ready to be decannulated. And there's another protocol here as well, where they talk about safety screening and non-ECMO FiO2 titration and 30-minute ECMO-free trial with the sweep gas flow turned off, and then obtaining gases. With all this, I've actually not spoken much about pump-controlled trial off, because I have not come across many neonatal studies or neonatal institutions where neonatal weaning is done that way. I'm curious to hear more from the panelists and the moderators. And so I'll leave this here for just a brief second. This is a PediECMO site where we have quite a bit of information on, and we also conduct webinars and such, and membership is free, so please feel free to join and utilize this opportunity to learn more. And I will now stop, and please feel free to ask questions. Over to the moderators. Do I stop?
Yeah, you can
Sharing?
share the screen, please.
Okay. And
Well,
really,
thank you
thank you
so
so much
much.
for
Thank you
giving
so
this
much for your presentation. I can see that Dr. Diana Vargas just joined as one of our panelists. She was missing at the beginning. Hello. So now I will encourage you to please type questions in the Q&A box so we can start opening up our panel discussion. I know, Florian, you want to take over?
Yeah, thank you very much, Sharada, for this really nice talk, very practical aspects in it. I really like this also that you showed us the difference between VA and VV ECMO. Can I ask you a question? When you presented your data on the weaning this patient from ECMO and you go down with the flow, is there any reasonable risk to expect overwhelming clotting and loss of function of the oxygenator? And is this the why you give some heparin or bival, or can you explain on that?
Yeah, absolutely. I mean, the surface area is large and then the blood flow is very minimal. So you can actually see you can see the beginning of fibrin if you leave for more than 10 minutes. So like by around 10 to 15 minutes, we do the flash. Usually once we do the trial off, within 30 minutes, we kind of have an estimation of, okay, when the OR can come and decannulate. So ideally, hopefully we don't have to stay clamped for a longer period of time. And that's why the human factors and the organizational factors are so important to really assess this readiness so that they can just come and do whenever it's possible.
Yeah, I would like also to ask any of the panelists about this. You know, VA weaning off VA ECMO is not always that easy, right? So as Sharada mentioned, you know, we put babies on VA because we want to rest the lung and the heart, but really the LV is not completely rested, right? As we know, there is an increase in the afterload given by the arterial cannula. There is LV and diastolic pressure, increase in the wall tension, and there is decreased coronary perfusion as well. So the LV is not really in his best place. So once we start weaning the flow, you know, I know we follow with echo, and I know, Sharada, you mentioned TE in neonates on ECMO. We will never, right? Like, and especially given the size of the patient and the patient is anticoagulated. So we do transthoracic echoes. But how to predict, right, this myocardial or LV function adaptation once we are weaning the flow and increasing the preload, right? Because if we get echoes during full flow ECMO, really, they're not very well informative if there is no preload in the ventricle. So how to predict this, how slowly to wean the flow. At CHOP, we have our own protocol and we do it in a specific way. And do you get an echo? At what time? At what flow do you think is best? Or you clamp. Some people don't clamp. Some people do low flow trials and get echoes with a flow of 30 per kilo per minute. So anyone can, I'm sure everyone does different things. So that's why it's so important.
I think that's a beautiful question, Maky. And actually had a similar question on that vein for Dr. Gowda and everyone. So maybe I'll build off of that and add my own question. But I think, at least for me, I came from a non-hemodynamic center when I did my ECMO training, and we had the same impression that, you know, an echo on full flow is basically useless to you. So I totally understand why, and the loading conditions you mentioned are completely valid. I think what we've found now at a very heavy hemodynamic center, we still actually get serial echoes even on full flow. Certainly we use them to guide weaning. But if anything, I find that it's more my RV on full flow that's going to be more compromised, right? Related to, especially, we only do VA ECMO here, so you have like zero preload to the RV, it's all being sucked out. So typically, even if otherwise we've been on for a while, we would have expected the RV to recover, we tend to still see even subtle markers of RV dysfunction. But our LV, if recovered, typically we would expect and usually see only improvement as we start to wean flow. So it's helpful for us anyway to monitor serially and see is my LV improved, recovered, and is my RV at least stable? And then as we follow continually off of flow, we see those changes, and that's helpful. But I'm curious if anyone else is using echo on full flow, and do you interpret that in any way?
So I'm going to take a small diversion here. I think your statement is so valid, Rachel. Even when we say full flow, you're really never at 250 mLs per kilo per minute, right? So when you're looking at it, like, 120, you still have some preload. You still can assess the RV function more so than the LV function, obviously, but you will get some data that will prepare you while you're doing the trial off to help titrate the vasoactive medication, or maybe think in terms of SVR versus PVR concerns, or maybe if there is any valvular regurgitation, those things still, if you have mitral regurgitation at lower volumes, obviously what will happen if you continue to keep the afterload, and then now you have higher volume that's going into the left atrium and left ventricle, you will have exaggeration of that mitral regurgitation. So I think that definitely gives you some element of, okay, what my next steps are going to be. But I'll wait for others to answer as well.
I can add from our experience at Columbia. I agree with what Rachael said. I think starting with a full flow ECMO, it's really like a baseline, and then you just assess from there as you're starting to back off on the flows. I would say we rather back off relatively fast, every 3 to 5 minutes, to preserve the circuit, and rather clamp and observe clamped on a bridge for, depending on every patient, the babies were like 30 minutes would be enough, but there are patients that need a lot more titration, and probably I think the longest bridge we've been done is about 2.5 hours. Making sure that the cannulas are flushed, and that, if we have to go back, there's no clots, etc. But I think we would often actually do an echo even before we're doing a true clamp, just to prepare the patient. We'll do a wean trial just to assess, not necessarily with all the support, but it gives us an idea what the patient's going to need. And several hours before what we actually consider is going to be the wean trial, we start the epinephrine, and we try to put pretty much everything in place by the time we start to wean, and really focus on clinical changes, as you mentioned, Sharada, blood pressure changes, NIRS changes, and very frequent gases every 5 to 10 minutes to assess the changes and make that decision, more than real-time echo, as you very, very nicely presented.
Yes, and Marie, your hand was raised.
Yeah, no, and actually I'm back up on the unit while my colleague is actually weaning a little neonate. So I'm living it in real time. Interestingly, this was like a former preemie, a month old though, with influenza B. So potentially a little bit different than, the post neonatal cardiopulmonary failure. But I think one of the things that, and I'm glad you said that we never, full flows are not necessarily, it's a qualitative aspect. My Christmas cup this year was Anne-Marie hates full flows as a term, because depending on the size of your cannulas, you can be 120, you can be 140, you can be 160. So it's really important to understand where quantitatively you start. And some patients, even at, I'm going to say at the peak flows that you can achieve in your cannulas, their RV may not be offloaded, right? Depending on their condition I think it's Diana's point and Sharada's point, you'd want to know where you start. And then when you wean, and there may be an opportunity to improve that even before let's say on Monday, if we think of this patient on Monday, that's at the baseline, I'm going to say elevated flow echo showed us that we weren't necessarily where we wanted to be in terms of how the cardiopulmonary, I would say, wellness appeared. And then we added some medications. We added bronchoscopy the next day to make sure that there wasn't anything compromising the achievement of what, one might say are the FRC, and then we can talk about that separately, but also where would be your, I would say, your lowest mean airway pressure for optimal RV and LV wellness. And sometimes it takes a couple of days to get to that because the babies may not tolerate it. I would say their optimization and then their wean on the same day, because definitely they can be disturbed by the optimization phases. And the one parameter I think that colleagues didn't mention that I still observe and follow like a hawk is the heart rate in these babies. I understand that sometimes some pharmacological, measures will blunt our heart rate response, but it's often, if I can't get the echo team at the time to start my wean and they come in a little bit later, the heart rate is really, I would say, a parameter that's very, very valuable in these little ones.
Yeah, for that reason, I actually dislike if the patient is on dexmedetomidine because like it blunts the heart rate to such a large extent. Then you can see that sudden hypotensive episode, and you're kind of like pouring in volume and trying to resuscitate and going up on epi. Yeah.
Okay, thank you. We can move on to some of the questions from the audience. Our first question says, does the echo is always required for weaning from VA ECMO? And this person's second question says, how we can know if the coronaries are fed by oxygenated or deoxygenated blood? For anyone.
Well, I have a little disclaimer here because just to answer something, I'm not too experienced with VA ECMO. I have worked for many years at a center where we almost exclusively used VV ECMO, or for at least for the last 8 to 10 years. Before this, we have done VA ECMO, and I now changed to a center where VA ECMO is used. So this is really a nice experience to get experience with a really new or completely new technique for me. But to answer this I would say the TEA is usually not used for weaning VA ECMO. There are also some limitations like the size of the patient, and the probes are not like broadly available for neonates, and they're very expensive. It's a nice way also to have a look on the cannula position, but usually for the neonates it's not available. And I don't know if any one of you are using it for neonates or pediatric patients maybe.
Yes, pediatric for sure, but not in
Yeah. Yeah.
Yeah, so I would say to going back to the question, is it always echo? I assume he means echo in general, transthoracic, required for weaning from ECMO. I think it is, and I think it gives you a very useful information while you are increasing the preload. So I think it is part of the trial off from VA. I don't know if anyone wants to answer the second question. My answer would be that we don't really know how the coronaries are being perfused. There is a theory that there is some retrograde flow from the arterial cannula, that could go back into the AC and then aorta, back into the coronaries. But there is also always LV output, native LV output, that will perfuse, the coronaries with blue blood. So I don't have a better answer to that.
I always got told that the coronaries are perfused by the oxygenated blood that is still oxygenated by the rest of the function of the lungs. But I don't know if this is the experience that you all have, or whether this is just a rumor.
I think adult studies definitely do have, and even larger pediatric studies have coronary sampling, especially if there is LA event and such, that they can see the pulsatility index changes the amount of oxygenated blood and the CaO2 in the coronaries. But this is with the real estate we have in neonates. Definitely, we are not doing that. You do not want to poke a hole in that coronary, so we have to probably, this is where I would extrapolate from the adult studies and say, if I don't see any LV function, and if I see the aortic valve is struggling to open, I'm not getting oxygenated blood to that coronaries. That's probably how I would interpret that.
In that scenario, you're more likely to have retrograde filling from the aortic cannula,
Right.
which would oxygenated blood by the
Yeah.
circuit. As I think as long as you have pulsatility or ejection and opening of the aortic valve, you can assume that the intrinsic LV output is what's perfusing the coronaries.
Absolutely. So yeah, that's the only way we can know for sure whether it is when the baby is getting oxygenated blood is when there's complete standstill and myocardial stun, and then you have the retrograde blood, oxygenated blood. But any other time, it's just a guess.
Sharada, can you comment on another question from the chat? There is a question on the timing of repair of CDH patients on ECMO, and I think that's a great question and also a great way to introduce this as a way of weaning from ECMO.
Yeah, for everyone. I mean, all of you panelists and anyone.
Yes.
Yeah.
Sorry.
Yeah, obviously our center, we operate on ECMO. We've always, we've done it for a very long period of time, so we don't really wait for the patient to come off of ECMO. And we, yes, we do wait for the, hemodynamic stability in terms of like at least the transitional circulation and hoping that the PVR drops a little bit, but we don't wait for the baby to completely be normotensive from the right ventricle perspective, if that's a question. So we have been an early repair center. So
I think that's a very loaded question because that's like, we don't have literature to guide us, right? And I think you're definitely going to get center-dependent answers. And this isn't an anticoagulation talk, but obviously like those risks and dangers, there's a lot that goes into that decision, right? We have done both at our center. And then I just wanted to make a small comment too to the previous question about like size limitations for echocardiography. At just, point like from our center, we don't have a smallest size that we echo babies. And certainly the size, like the smallest size that you'd be on a baby on ECMO anyway, like in the high ones. If you have, the experience, it's definitely doable. We find, at least routinely, we would use echo with each patient that we're weaning.
Yeah, I was going to say, speaking of timing for repair CDH on ECMO, as you know, there is no literature telling you exactly when the indications are, but CHOP as a big center for CDH, in those babies with severe CDH, severe prenatal numbers, we are actually moving to being more aggressive and repairing these kids in the first maybe 24, 48 hours after going on ECMO. Because, after going on, we know that they become, they develop anasarca. So it's much more difficult to, no one will operate on a kid like that. So we are trying to do them earlier, especially those kids that have a big portion of the liver in the chest, just to remove that and hope that by moving the liver down, we will be able to recruit a little bit of the small lung that is in that side. So we have been doing and trying to do them early on ECMO.
I agree with Maky. I think we divide or try to, because this is hard to know from the beginning, but the babies that once they go on ECMO, we anticipate are going to be in ECMO for several days, meaning 3 to 5 days. We tend to go on and repair early. Compared to a baby that had been relatively stable on low event settings and had that one event of decompensation that spirals into an ECMO cannulation, we're more likely to be, let's decannulate soon and then go to repair once the pH sort of has subsided slightly.
Okay, there is another question here that I just want to read out. It's a little bit long. At my institution, decisions are based on subjective parameters for RV function and not information on PVR, like PA Dopplers. If there is septal flattening, it is considered suprasystemic pulmonary hypertension. My understanding is that PA pressure is dependent on PVR, pulmonary blood flow, and LCWP. If we start with high PVR and low pulmonary blood flow after initiating pulmonary vasodilator, PVF will increase, PVR improves, and PAP pressures may be considered abnormal based on IV septum configuration. If there is clinical evidence of adequate PVF, would you disregard septal flattening for your decision on decannulation? It says this is an actual case they are dealing with right now. Anyone?
Yes, so I think if you now have adequate pulmonary blood flow, like septal positioning, right, is just going to depend on differential pressures, right? So if you have, for instance, maybe your baby's a little bit hypertensive, I mean, that could impact, or hypotensive, excuse me, could impact septal flattening, even in the case of adequate pulmonary blood flow. So I think that could certainly play into why you're still seeing that.
Paying attention to the RV functional parameters, and then if we need to offload the RV somehow, might be something that I'd look in here, but as long as the pulmonary blood flow and your QP is adequate, and then your LV preload is not affected because your QP is impaired, I think we can at least benign neglect for the septal flattening. But if the RV strain pattern, if there is RV strain pattern or anything like that, then you'd have to pay attention to that.
Anne-Marie?
Anne-Marie, do you want to comment on it?
I was going to comment, those are the types of babies where I see like the role of the faculty hovering over during the wean as being very, very important and critical. So it's not just, you know, understanding whether or not the patients are going to fail because of gas exchange, but it's really understanding the impact of the gas exchange and potentially a little bit of acidosis, a little bit of hypercapnia and its impact on the RV, and not just the septal sort of potentially flattening, but whether or not then the RV looks like, I call it, you know, the bullfrog of the, you know, and they need a little bit also more of your time at the bedside and maybe a little bit longer wean to be able to declare themselves. And therefore, you're going to want to optimize your anticoagulation, potentially anticipate a longer wean. So they deserve a lot of our attention. Those are tricky patients.
Great. So I don't see any more questions, but I have another question to all of you. And I'm interested to hear what you do in terms of lung recruitment. How in babies or in pediatric patients on VA ECMO. So how do you manage the ventilator? What mode of ventilation do you choose while on VA ECMO? Do you usually maintain or try to maintain the lungs recruited open? What do you do in those cases that they white out? What do you do with the ventilator, with the nitric, and how do you re-recruit those lungs? And my last question is there any role for lung lesion dexamethasone? Who wants to start?
It's
Well,
a
I
very
think that's
polite group here.
yes, hey,
Maky.
please,
It's a very
everybody.
polite group.
Well, I would say in the past, I was more keen to reduce the ventilator settings. And then I had the feeling that the whiteout was more pronounced and the lungs took longer to get back to a proper volume. So in recent years, I have not done that much. I kept the PEEP at a normal level of like 4 to 5 or so, and the inspiratory pressure also on a normal value, and then just reduce the frequency a little bit. Yeah. But then again, mostly these patients were on VV ECMO, so the respiratory support still played a role there. Yeah. So.
Yeah, I'd echo, I mean, Florian's comments about not trying to completely collapse. We actually have a little bit of a higher rest strategy than that even. We'll rest, I mean, depends on the initial indication for going on, but like with PEEP of 10 actually, and then like a low rate of 10, like PIP of 20 total, like a longer eye time, and then try to be really careful about fluid balance even early-ish from the beginning. We had empirically put everyone on, and now we kind of are more selective about CRRT into the circuit, but careful attention to fluid balance has really played in strongly to that lung strategy. And then just trying to have careful rest time until cardiac recovery, and then gentle recruitment, which is staged, over time. But ventilator based, and using a conventional ventilator can be helpful too, because you can start to see, your loops, your volumes. It gives you a lot of good information. So that can be helpful as you start the re-recruitment process.
Any
Yeah,
good experience with APRV after lungs are whited out for lung recruitment? We have it really works for us in those cases that the lungs are completely white out.
Diana, what do you want to?
Yeah, no, I was going to agree with you in a sense of moving away from completely rest settings and maintaining normal expansion, particularly the contralateral lung in CDH, which is about 8 ribs expanded, and every patient is a little bit different, but we either would have a higher PEEP strategy, as Rachael shared, or at least keeping a tighter volume around 4 per kilo with a lower rate and an extended eye time.
Thank you. Carolina?
Hi, so we don't do ECMO at my center, so I'm not, I don't have any experience on that, but my question is regarding the TN echo follow-up. Is there a parameter that is more useful to you? For example, tissue Doppler assist more like loading independent? And also for the weaning, do you use long ultrasound?
Who wants to comment? Rachael, do you want to say something?
Sorry, I can jump. Yeah,
go ahead. Please go ahead.
No, we do use tissue Dopplers as part of our functional assessments. But for the RV, our primary drivers would be tissue Doppler, like an S prime in a 4-chamber review, and then along with the TAPSE and FAC. And then for the LV, we're still using Simpson's biplane, as well as your TDI measurement. So we continue to use everything, and then just try to see what our trends are over time, particularly as you wean off. So yeah, tissue Doppler is helpful, but we're not doing all of our normal assessments too, in our experience.
How about lung ultrasound? I really love lung ultrasound to see during a week of ECMO to see how the lung is aerated. But I think that's still developing and not so frequently used. I don't know, Anne-Marie and Diana, if you use it in your unit?
Not currently for sort of clinical decisions. It's mostly we would use it for air leak, but not necessarily for recruitment assessment.
Yeah, we'll use it more for decisions about drainage, empyema, but we recognize that there is an opportunity to consider it in terms of. We don't necessarily integrate it in the decision-making for weaning, but it doesn't mean that it couldn't necessarily be done. And I think, Maky, one of the things, we're still a very high bronchoscope user, mostly in the sense that a little bit like some people have said, I think we've moved away from, the full, no ventilation during ECMO. There's no point in trying to, go from I'm going to say rest the lungs like pancakes and then expect them, you know, on the day that you want to wean for them to be functional. So often, you know, 48 hours before, you know, we'll try to understand if we get tidal volume, understand the minute volume, understand the pressures that are needed to get whatever volumes. And we assume that you have to get volume to eventually get function. But not all patients, especially the ones a little bit like the one I was telling you about just today, if they're more of a indication in the context of an infection, for example, as opposed to pure cardiopulmonary from RV failure, they may need a different approach to recruitment and or, you know, acquiring the lung volumes without barotrauma slowly. And they may need a bronchoscopy because it's sometimes not always, I think we will get fooled by, you know, opaque lungs without necessarily excluding if there's an endobronchial cast or thick secretions. And I think, you know, with small little bronchoscopes, it's very amenable to, if without doing a full lavage, at least ensuring that your endobronchial tree is patent and ready for recruitment.
Right. All right. So I think we are almost out of time. So I think we can conclude here. And I just want to say thank you, everyone. Thank you to the speaker and all the panelists for this wonderful discussion. And thank you, all of you, for joining today, our webinar.
Thank you. Bye.
Thank you. A great discussion. Thanks. Bye-bye.
Thanks. Bye, everyone.
Thank you. Bye.
Nice meeting everybody.
Same here. Bye.
Thank you. Bye.